Hello, my name is Eula Tetangco and I'll be presenting this month's Journal Club. Thank you to Dr. Tausif Ali for spearheading this activity. Let's discuss the article by Eula and colleagues entitled Ileal and Rectal Ulcer Size Affects the Ability to Achieve Endoscopic Remission, Post-Hoc Analysis of the SONIC Trial, published in the August 2020 issue of the American Journal of Gastroenterology. In Crohn's disease, symptoms correlate poorly with endoscopic disease activity. Targeting clinical remission alone has not shown to alter disease course or improve disease-related outcomes. However, endoscopic remission is associated with improved clinical outcomes. As a result, guidelines suggest that endoscopic remission should be a treatment goal. However, it's unclear how baseline endoscopic characteristics, such as the overall degree of inflammation or location and size of ulceration, affect the ability to achieve endoscopic remission. The primary objective of this study was to evaluate whether the overall degree of endoscopic inflammation at baseline affected the ability to achieve endoscopic remission for both the entire ileocolonoscopy and for individual segments in the bowel. This study used publicly available data from the 2010 SONIC trial. It included 172 adults with moderate to severe active Crohn's disease and inadequate response to conventional therapy. Median disease duration was 406 days. Patients were naive to immunomodulators and biologics. They were randomly assigned to either infliximab 5 mg per kilogram at standard frequencies, azathioprine 2.5 mg per kilogram, or a combination of both. The primary endpoint was corticosteroid-free clinical remission at week 26. Endoscopic inflammation was scored by a single blinded reviewer with two commonly used scoring tools: the Crohn's Disease Endoscopic Index of Severity, or CDEIS, and the Simple Endoscopic Score for Crohn's Disease, or SES-CD. For both scoring tools, the ileum and each bowel segment were rated separately. For the entire ileocolonoscopy, overall endoscopic remission was defined as SES-CD, or CDEIS of less than 3. For individual segments within the bowel, segmental endoscopic remission was defined as SES-CD, or CDEIS of 0. The study excluded patients with low endoscopic scores at baseline, including those with CDEIS less than 3, SES-CD of the colon less than 4, and SES-CD of each segment less than 2. Large ileal and rectal ulcers, defined as greater than 2 cm, were less likely to heal compared with smaller ulcers. The size of colon ulcers did not impact endoscopic remission. Large and deep ileal and rectal ulcers were even less likely, about tenfold less likely to heal, compared to superficial ulcers. Additionally, ileal ulcers were less likely to improve than colonic ulcers in any segment of the colon by week 26. Interestingly, high SES-CD scores of at least 16 or CDEIS scores of at least 12 did not affect the rate of endoscopic remission by week 26. The study's strengths include the use of standardized endoscopic scoring systems. The study also compared patients with superficial ulcerations at baseline and compared patients based on the size of the ulcerated lesions. Additionally, the study adjusted for confounders that may influence endoscopic remission, such as disease duration and presence of perianal fistulas in the case of rectal ulcers. This study's limitations include that of the SONIC trials. Namely, patients who dropped out before 26 weeks did not have a second ileocolonoscopy, so selection bias likely exists for those patients who continued to week 26. Because the study reports the results of multiple comparisons, it is possible that some significant results are because of chance alone. And it is important to note that, as with any post-hoc analysis, the results are meant to be hypothesis-generating and do not confirm a hypothesis. The optimal time point to evaluate for endoscopic remission in Crohn's disease remains unclear. The STRIDE consensus statements identify absence of ulceration as a treatment target and recommend ileocolonoscopy at 6 to 9 months from starting therapy. This study indicates that large and deep ileal and rectal ulcers in Crohn's are less likely to heal compared to colonic ulcers within 6 months of treatment initiation. We should keep this in mind at follow-up colonoscopy when evaluating mucosal healing. Validation of these findings in a prospective cohort may help optimally define endoscopic remission goals in clinical practice and clinical trials. Thank you for listening, and I look forward to our discussion.